Hello everyone, welcome back. This is Dr. Harshavardhan from Vice Academy. So as you know that we have been doing some videos to um, create interest among our urology students. So this is one of such lectures. Today we are having an eminent andrologist, Dr. Surendra Reddy. He is from Hyderabad. He is working as a senior consultant at Androcare Research Institute, which is a premium andrology institute in our country. And he's a senior andrologist. So today we have roped him. He will be sharing his thoughts on andrology, and he will be demystifying some myths about andrology. Especially this video will be useful for all our urology aspirants and also urology postgraduates. So this is a very important video. I hope you will enjoy the session. Over to you, Dr. Surendra.
Thank you, Dr. Surendra. I am practicing andrology since years. So Harsha had given a topic to talk regarding andrology. So I'm very thankful to you, Dr. Harshavardhan, and all viewers who are seeing this video exclusive. Is a broad one. I can divide this into two topics. One is the fertility, and second one is the sexual dysfunction. These are two parts. So this is a big topic. I will give a broad overview on this, and this should be useful for the postgraduate student in the form of either entrance exam, or if you are participating in a quiz of andrology. Usually, I am expecting this will be useful. In next videos, if that Arsha gives a chance to me in near future, in elaborately, I will discuss all the andrology topics. So first, as I told just now, I'll discuss regarding the male infertility in a broad view. So whenever a couple comes to you, you should have to take the history very properly. That is very important. Not only here, I am not discussing entire paper book story like that. What are the clinical implications which are useful as a practitioner? And also if you want to have a knowledge on the male infertility. So whenever a couple comes, you should have to know what is male infertility. Means if the couple, they had married at least for 12 months. Along with, they should have unprotected intercourse for minimum of 12 months. That definition of male infertility. They are not get a baby naturally. So what are all the causes? If you see, the most common cause is the idiopathic cause. Really, that is a frustrating to the patients and also to us. Why? Because after evaluation, everything, what we came to know, you can tell that it is idiopathy. So they won't accept. That is a problem in infertility of male. So the next most common cause is which is a most common correctable cause is the varicocele, and others are many like infections, tumors, or other inflammatory diseases. So many more are there. And whenever a couple comes, take an exclusive history, just a history, you will came to know much more information slowly. Why? Because the second part of this history is, these are the privacy issues. Most of these patients are initially, they don't tell true things. They want to mask it. They want to do something. They want to tell other things. And exclusively just beside his wife is there. So first you should have to improve confidence as he has to tell the true things. So now come to our topic. Usually the first test for a male, whoever comes to you for fertility issues, we have to do the semen analysis. Whenever you see a semen analysis, so diagnostic centers won't give a clear picture about the semen analysis. They should have to do a exclusive, CASA is best one, computer-aided semen analysis is best. That test, in that way, if you do, you came to know what all the components are there. In the semen analysis, first component, what you should have to do, see is the volume of the semen. Volume of semen is very important. It's a simple thing. When you receive the report, they will give, according to the WHO latest guidelines 2021, July, the 6th edition manual came. 1.4 ml per ejaculate is the normal value. So whenever you see that volume of less than 1.4 means 0.4, 0.6, 0.7, usually you can suspect an obstructive case. So means if the report came as azoospermia, then you can immediately say it is a obstructive azoospermia. Why? Because most of the 80% of the semen comes from semen analysis. You can expect pathology of the either absence of seminal vesicles or hypoplastic. This hypoplastic seminal vesicle associated with the absence of gas, like that you should keep your mind. Second thing, the pH. Normal pH is a little bit alkaline. Again, the alkaline pH is because of the seminal vesicle components. So again, you can expect the either the obstruction or pathology at the level of seminal vesicles. And the third component you should have to know it. What is sperm count? What is sperm concentration? Sperm concentration means how many sperms per ml is the sperm concentration. And whatever ejaculate had given, maybe 1 ml, 2 ml, 3 ml. The sperm concentration into volume is equals to the total sperm count. You should have to know difference between concentration and the count. Never see, if you see, he has given 6 ml. And for example, his count is 3. Sperm concentration is 3 millions per ml. If you see the sperm count, 3 millions into 6, 18. So whoever sees, or even the simple physicians, oh, 18 millions, it's normal. It's not correct. It's the sperm concentration you should have to know. And the second component, next component is the motility. In that motility, the progressive motility is important. That progressive motility, latest guidelines is 30%. And the third question, always they will just ask total motility, progressive motility, usually. So the sperm progressive motility is the 30%. Then you should have to see the sperm morphology. Morphology means structure of the sperm. Minimum is the 4%. And next component is the whether there is any pus cells are there that indicates any presence of infection. That should be less than less than 1 million, you can take that one. So they are the simple concepts. If I tell all these components, again, you should have to open your book. In books, everything is there. See the volume, pH. Third component I missed is the presence or absence of fructose. If really fructose is absent, that indicates again seminal vesicle pathology. It's a clear-cut obstructive azoospermia, or you can suspect either ejaculated obstruction at that level also you can suspect. So progressive motility 30%, morphology 4%, any component of infection is there. These you should have to check in a simple semen analysis. And whenever you see a report, you should have to know the terminology. What is azoospermia? What is cryptozoospermia? What is necrozoospermia? What is oligospermia? Oligoisthenospermia. Azo means the complete absence of sperm in the entire ejaculate. Never tell or diagnose it is azoospermia if you see only one report of semen analysis. Again, guideline says it is at least 2 samples. And second most important is you should have to see that is a centrifuged sample or not. If it is a centrifuged sample, no sperm, you can label it as azoospermia. And second one, oligo. Oligo means number. If the count is less than 16 millions per ml, means, again, I am telling it's not count, it's a sperm concentration. So then they can diagnose it as oligo. Third component, motility. If less than progressive motility 30% is there, then it's the easteno. If it is very severe, like 2-3 millions are there, usually they will put as severe oligo. Easteno means morphology. Less than 4, they will give it as severe oligoisthenoteratospermia. So teratospermia means, oligo means count to decrease. Eastheno means, sorry if I missed that one. So motility. Oligo means only count to decrease. Eastheno means it's a motility decrease. Terato means it's the morphology. So OATS means oligo, count to decrease. A means eastheno, motility decrease. Teratome means morphology decrease. So this is the entire diagnosis. So then what is cryptose? Cryptozoospermia means usually if you are seeing 1, 2, 3, 4 sperms, means single digit sperms are there. Usually that is a cryptospermia, not millions. It's a single 1, 2, 3, 4. Necrozo means complete zero motility. You are not seeing single sperm moving. That is called necrozoospermia. Really, we don't know there is complete dead cells or immotile sperm. For that, next step is the vitality they will check. The vitality should be at least 52%. So that should be a normal semen analysis. So again, I am telling oligo means decreased sperm concentration. Eosino means motility decrease. Teratome means morphology decrease. 2 centrifuged samples, no sperm, it is an azoospermia. So that's why you have to check the semen analysis actually. And next component, whenever you see a less count, how you should have to investigate. First, you should have to do clinical examination. What is the status of the testis? Means size of the testis, consistency of the testis, epididymis, whether it is bulky or thick epididymis is there, presence or absence of vas difference. All these we just came to know by seeing the clinical examination. And absolutely you should have to check for the our penis for phimosis. So couple comes to you, they are telling that we have a good sexual frequency, everything is there, but we are not getting children. Why? Because of the complete phimosis. They don't know it is whether it is coming out or not, or excess skin is there. After the orgasm, he is coming out, entire semen is coming out. So you should have to check for phimosis. So in clinical examination, these are sufficient. Next, what investigations you should have to advise? Simple hormones. What hormones? Testosterone total, FSH, LH, prolactin. These are sufficient. Why? Because testosterone is important for spermatogenesis, and FSH, LH again important for the LH, the component of testosterone, FSH for again spermatogenesis. Prolactin usually indirectly it will help. Hyperprolactinemia decreases the testosterone. That impacts the sperm. For that, we should have to do prolactin. Patient is obese, right? Estrogen also, E2. Why? Because all the testosterone converted into estrogen. You should have to check the ratio of testosterone to estrogen. For that, because if he is obese and alcohol, only you should have to write estrogen. So these are the hormonal blood test you should have to do for a couple, for the male factor. Third component, already I examined clinically. So any varicocele is there, I missed in the clinical examination, grading of the varicocele, which is very important. Clinically palpable varicocele only you should have to do surgery. So clinical examination, very important to grade the varicocele. If you do the ultrasound, your clinical examination findings, whether they are correlating or not, you came to know by doing the simple ultrasound scrotum. They will give the size of the testes, epididymal status, varicocele, everything they will give. So that's a simple non-invasive procedure. And if you see low volume semen, it's a azoospermia, absent fructose. So all these acidic component, then you should have to check for transrectal ultrasound. Do a transrectal ultrasound. You should came to know presence or absence of vas difference, any ejaculatory duct components, midline cyst are there, or the posterior urethral, or the opening of the ejaculatory duct. Everything you came to know. Depending upon the analysis status, you can advise plus or minus transrectal ultrasound. And when you should have to do genetical testing. Latest guidelines is before it is azoospermia, but now it is less than 5 millions. Sperm concentration less than 5 millions. Usually you should have to check his genetical testing, which includes only 2 components. One is the karyotyping you should have to do. And second one is the Y chromosome deletions. So whenever you do Y chromosome deletion, there are 3 factors, AZF, ABC. If you see deletions in the A, B, C, usually if you see C deletions, then only, even if you do TSA or micro TSA, you will get sperm. If it is A and B deletions are there, it is very difficult to get the sperm even in sperm retrieval process. For that information gives by checking the Y deletions. And if there is either single or double VAS difference and bilaterally VAS is absent, then you should have to advise CFTR gene mutations. Their correlations are different. We'll tell in the next coming sessions. So if it is a AZU with absent either uni or bilateral VAS, you should have to advise CFTR gene mutation. So these are all the investigation, regular investigations you should have to do. If the couple has recurrent miscarriages, then you should, or the semen analysis show significant puzzles, you should have to advise semen culture 1. Specifically, either 3 or more than 3 miscarriages, early pregnancy loss is there, you should have to advise DFI testing of this one. Means DNA fragmentation index. Normal value is less than 15%. 15 to 25 or 30 will take it as borderline. More than 30% always abnormal. For that, what we should have to do? Consequently, we can discuss. So these are the investigations. Depending upon that, we can do. So then, how you should have to treat these patients? Again, you have to categorize these patients into 2, whether it is an AZU or it's a severe warts. If there is a severe warts, already we discussed hormonal component is there. There is a decreased testosterone. Usually we'll take it as normal is at least 250 nanogram per deciliter or 2.5 nanogram per ml. So less than 2.5 or 250, you should have to supplement to improve the testosterone. Never give any active form of testosterone for a man who is planning for fertility. Why? Because that suppresses the testosterone. Either tablet, you should have to give HCG. The doses we'll check. So you should have to give only HCG to improve. Otherwise, if FSH is border below 7 only, you can advise clomiphene citrate 25 mg at least for a period of 3 months. Why? Because one spermatogenesis cycle is the 3 months. That's it. So number 2, if estrogen is high, low testosterone, we can advise to take letrose 2.5 mg for a period of either alternate day, preferably 2-day gap. You should have to give letrose. Why? Because if you give daily letrose also, that makes very low estrogen should be a minimum for us. So again, that will also impact his erectile dysfunction. So that you should have to give either 2-day gap or alternate day, depending upon the level of the testosterone estrogen ratio. So that is the hormonal manipulation. And third, any infection is there according to culture sensitivity, yes, we can give the antibiotic. And third component, very big market, nutraceuticals, antioxidants. So antioxidants, yes, they are working. If the patient has a low sperm concentration and also the motility low, and you can advise the antioxidants exclusively coenzyme Q10 should be there, minimum 100 mg per day. We can put usually 2.5 to 3 months. That's a spermatogenesis cycle. So in this way, you should have to evaluate and proceed. It is a simple case. Then azoospermia, so I'm clearly telling, I'm broadly telling it's not exclusive. So if it's azoospermia, you should have to divide into obstruction and non-obstruction. Usually obstruction means if there is absence of as nothing to do, you should have to TISA sperm retrieval and go ahead with the IVF fixing. And number 2, really there is a midline cyst or ejaculatory duct obstruction, transurethral, that ejaculatory TURED you can do. If you resect all these components, usually semen will come. You will see the sperm in the subsequent semen analysis. Third component is the non-obstruction. If there usually non-obstructive azoospermia, mostly is a testicular failure. You should have to know primary or secondary. Primary testicular failure means it's a at the level of the testis, the problem is there. If it is a secondary testicular failure, means from the brain, pituitary level it is there. Usually it is hypo. Primary testicular failure is usually hyper is there. If you do all these testosterone, FSH, LH, you came to know whether it is a primary testicular failure or the secondary testicular failure. So usually, if it is obstruction, I told either it is a TISA, direct testis, preferably try to do PISA. PISA means percutaneous epididymal sperm aspiration. Epididymis is one component where the sperm attains its maturity and motility. So first try to do PISA, then you are not getting, or dilated epididymis is not there, you won't get anything. So then you have to do TISA. It's a non-obstructive azoospermia. You can try TISA, but you get sperm in the TISA if everything is okay. If the embryologist does not see any sperm, then you should have to send for a histopathological examination. Then the biopsy report will come. Biopsy report usually comes either if everything is okay, presence of spermatogenesis up to the level of mature sperm, or up to the level of spermatid, or late maturation arrest, early maturation arrest. Only low volume is there, hypospermatogenesis, or Sertoli-Selonli syndrome, bar germ cell aplasia. So these are the HPE reports. Depending upon that, next what you have to proceed, either again repeat TISA or micro TISA. That depends upon the HPE report. So in this way, you should have to evaluate a couple who comes to you. So I had given a broad categorization only, not an exclusive treatment for AZU or severe ORS or something. Now I am concluding fertility part here. Very important, what you should have to know as a urological surgeon, here it is. If you see clinical varicocele along with radiological evidence, the best procedure for varicocele is microsurgical varicocele correction in every form, like very low recurrence rate, low chance of hematoma. Number 3, low chance of hydrocele formation. So in every aspect, when compared to either the lap or open procedure, even the embolization, the best is the microsurgical varicocele ligation. If you do microsurgical varicocele ligation, most of the patients, at least in 3 months, they will improve. For some patients, they are late responders. They may take 4 to 5 months also. So gold standard at present is for varicocele correction is the microsurgical varicocele ligation. Before doing surgery, counsel the patient. Really, if the counts are very low, like 2-3 millions are there, ask them to freeze at any IVF center. Why? Because you can't expect every time that will improve. Sometimes if time is not good or other factors are there, 3 millions comes to 1. Both couple will sit down in your room, or every day they will come to your OP, just irritating you. What happened after procedure like this, like this, like this. It is there. So counsel properly. Why? Because in the initial my talk, I told the most common cause for exclusive male infertility is the idiopathy. Counseling, then investigating, taking a proper history before that, proceed further for treatment. These are the key points in getting success in the male infertility in our regular practice. So thank you for this. And comes to the second component is the sexual dysfunction. Every time sexual dysfunction, everybody will think it is the erectile dysfunction. Sexual dysfunction includes again 2 components. One is the erectile dysfunction. Second component is the ejaculatory dysfunction. So I am dividing it into ED and EZD. So first come to erectile dysfunction. You know, sufficient hardness is there for penetration, and it should be at least 3 months. Then we can diagnose him as having erectile dysfunction. It's very difficult topic to discuss with the patient. Why? Because there has a taboo regarding sex in our cultures, exclusive our Indian continent. So whenever a patient comes to you, they never tell they had erectile dysfunction. They will tell there is a pain here, pain there. urine burning maturation or frequency of urine, then slowly, if he develops confidence on you, if you hear patiently, then he will tell that he has erectile dysfunction like that. So whenever it comes to a case of erectile dysfunction, again I am telling, take proper history. Why? Because the youngsters comes to you, sir, I had gone to my girlfriend, there is no erection, so there is no option for me, I want to go ahead with suicide. Why? Because I failed. It's the first time he has performance anxiety, and they had privacy or not, they don't know. So multiple issues are there. So in that way, you should have to counsel first. Again, I am telling here the most common cause for the erectile dysfunction is, again, it's a performance anxiety, which is a psychological component. Most of the cases you can't see any physical issues. That's the first one. Second component is the vascular issue. For the vascular issue, what we are doing is you should have to know the penile Doppler test. Third one is the hormonal. For that, testosterone total, prolactin, these two are sufficient. But if you want a clear picture, you should have to do FSH, LH. Again, patient is obese to estrogen. So they are the hormonal component. And fourth one is the neurological cause. Usually very rare, the patient has already spinal cord injury, either in the form of trauma or surgical issues are there. Then that's a neurological component, usually very low. How to investigate this patient? I told it's a history taking. Second one, penile Doppler. What you should have to know in penile Doppler? They will give clearly, if it is a good report of penile Doppler, you should see right, left, peak systolic velocities, PSVs and EDVs, end diastolic velocities, they will give. Peak systolic, so broadly I am telling, peak systolic velocity. So if it is a normal penile Doppler report is there, should be 30. 30 is the number. If you say above 30, it's a normal thing. End diastolic velocities, usually you should have to see, it should be below 3. Below 3 means 3, 2, 1, 0. If it is minus, that is very good actually. If end diastolic velocities are less than 30, so velocity means centimeter per second. You should have to diagnose a arterial insufficiency. If end diastolic velocities are above 3, you can tell it is a venous insufficiency. So that's a broad diagnosing how to interpret the penile Doppler test. So third component, hormones, I told it's a 250, usually will take it as a nanogram per deciliter, low testosterone. Not planning for fertility, you can give testosterone direct, but best check the FSH and give either clomiphene or check the E2, give letrozole like that. That's a hormonal component. Prolactin, I told. Prolactin normal will take that 15 international units is the normal. Above 15, not abnormal. If it is double the value, above 30, you can give cabergoline. If it is 50, same cabergoline 0.25, 0.5 weekly like that, you should have to give. So drug of choice is if hyperprolactinemia, cabergoline. And other hormones, E2, I just told, if he is a obese, you can give letrozole also, either in form of 2.5. That's it. And other investigations usually not required here. But in these patients, most of the times it is the performance anxiety only. Before we used to do this one, RG scans, NPT test, So, but practically no. So only penile Doppler exclusively for vascular issues. And other thing is here. Now everybody wants what is the treatment of choice, what drugs, what are the other components. PDE5 inhibitors, what you have to do, I told, say performance anxiety, you do office sildenafil test. Give a tablet of sildenafil 100 mg, ask him to stimulate. This is very important. They will take the sildenafil after 10 minutes or after, not it's a 10 minutes, sometimes they will take within 5 minutes, they will come, sir, there is no erection, sir. So at least he should have a audio visual. sexual component should be there. All these drugs never initiate erections. They will just maintain the erections. So he should have a audio or visual component of sexual content. Then in 45 minutes, whenever he will get good erection, so he will come to your chamber. Then you can check the hardness. You can tell that, have you seen? Yes, there is no major issue in you. It's your fear, it is there for you. So you can reassure him and go ahead. So office sildenafil test is best first one. No, really there is a component of erectile dysfunction is there. Then you should have to start with PD-5 inhibitors. 4 drugs available commonly: tadalafil, vardenafil, sildenafil, and avanafil. Tadalafil, how we can start is, if it is a regular, if the regularly they have sex, not a on-demand sex, daily dose you can put 2.5 or 5 mg tadalafil, or sometimes if on only on-demand, you can ask him to take 10 mg or 20 mg also just for on-demand tadalafil. You should have to tell that there is a side effect of either headache or mostly back pain. Mostly they have muscular pain. Back pain is there. Just tell them. Second component is the vardenafil. So if he failed with tadalafil, you can start vardenafil either 10 mg or 20 mg daily, or preferably it is again on-demand 20 mg. Sildenafil, you can start with 25 mg or 50 mg at least, not directly with 100 mg. You can put it on demand only. Sildenafil, to whom sildenafil, wife is working at one place at Bangalore. This person is in Hyderabad. Only the meeting is weekly. He had little bit fear. Then 1 dose, usually sufficient. So like that on-demand sildenafil you can give. And avanafil. So it's a recent drug and very short acting. On paper, articles, everything within 15 minutes. I can tell it is 30 minutes. Within 30 minutes, if you take, you will get mixed results I am seeing. So avanafil. These are the drugs. Along with that, very big market outside is the nutraceuticals, that L-arginine, Shilajit, Safed Musail. So number of components are there actually. Fenugreek. So goat with something, many components, they will in the form of powder sachet, they will come. So really don't know. But if you want, yes, you can add 1 sachet per day in a glass of water like that. That nutraceuticals. And hormonal component I told just now. So like this, the medical management, you can check. So if a person fails to have intercourse with all these drugs, then you can try intracavernosal injections. Intracavernosal, usually pepaverin. Pepaverin, low dose you can try actually. That is 30 mg per ml it will come. So you can take in an insulin syringe, if you take, it starts with 20 units only without dilation. 20 units means it will come half. So 15 mg. Like that you can give once injection, intracavernosal injection. Again, ask him to stimulate either audiovisual or at least stimulation he has to give. Now they come say that simple only pepaverin if you give, that's fine. If you responded, or bimix, trimix. Bimix includes phentolamine and the pepaverin. Availability of phentolamine is difficult, so chlorpromazine you can add. Trimix, pepaverin with phentolamine or chlorpromazine. Along third component is the PGE1, prostaglandin E1, alprostaglandin. These are trimix. That preparations, I'll tell in the next separate, it's a separate topic, I'll tell. So you can inject intracavernosally, stimulate him. Erection is there, ask them to have intercourse. That's vacuum erection devices. In these times, most of them are not using, because they have to put a constriction ring, then pressurize, increase the vacuum. It's a very difficult one. If patient is very more than 50 years, other issues or psychiatric component are there. That is important. So vacuum erection device not routinely we are using. And next is very latest, everybody fancy, low dose piezo shock wave therapies. The background mechanism is the neovascularization. Depending upon the companies, they are advising 4 sessions, 6 session, how many shocks they are giving. At our center, we are using Wolf company piezo wave shock wave machine we had there. So 4 to 6 weeks, 25 minutes, 5,000 shocks. Yes, really they are getting good response. At least patient, I don't think it's exclusive treatment or therapy. You can integrate therapy with the medication. Little bit, he will get good erections and he will have confidence and he will go ahead with his regular active sexual life. And another one is finally he's not responding for drugs, intracavernosal injections. They are not happy and they are feeling difficult with intracavernosal injections, not happy with the therapies. Then penile implant. So malleable and 3-piece. At our center, regularly we are doing the malleable, occasionally 3-piece. So in the malleable, Indian Surgiwear company Shah and others are Resiten, Promedon company Tube, Tatra, and depend upon the economical status of the patient, you can counsel and go ahead with penile implant as a last effort. So in this way, you should have to deal with a case of erectile dysfunction. Now comes to the second component of ejaculatory dysfunction. Ejaculatory dysfunction, usually it may be 3 to 4 types. One is the anejaculation, means he is not getting any ejaculation. Erections are good enough, but there is no ejaculation. It's a total anejaculation. Usually these patients, if you give vibration therapy 1, 2, 3 weekly, slowly, if there is no obstructive component, if they are not getting adequate stimulants at the time of intercourse, you can do the vibration therapy 3 to 4 times. Usually they will get ejaculation. Second one is the retrograde ejaculation. One is the most common cause, diabetes. Second one is your alpha blockers. For lower urinary tract, you can use LUTs, you can use alpha blockers that will make retrograde. And the TURP procedure. So all these cause retrograde ejaculation. And next one is the situational ejaculatory dysfunction. Means, sir, our gynec told to participate at this time. Little bit I am getting erection. Sometimes these patients won't get erection also. Erection is coming, sir, but ejaculation is a pure situational ejaculation. And one funny thing I will tell, the patient will tell, sir, I will get with masturbation ejaculation. Sexual component means with partner I don't get. Means he has a high masturbation. This stimulus he is not getting in the vagina. And another thing, sir, with masturbation I will get ejaculation. I had a girlfriend. With her also I had ejaculation. But with my partner, means with my wife I am not getting ejaculation, sir. So this is another type. This is a situational or partner related like this. So for all these things, usually most of the cases, there is no physical cause. It's purely psychological component is there. You should have to give sex therapy. You should have to counsel. You should have to talk them. Slowly, you will give. And another one is everybody will complain, premature ejaculation. So two either again definitions, if it is less than 1 minute or the partner preference. He is doing 5 or 10 minutes, his erections are good enough. But partner is telling that I want 25 minutes, 30 minutes. Again, he comes to us telling that, sir, I had premature. Hey Baba, how you are doing? 20 minutes already you are doing, you are telling premature. What the 1 minute fellow has to tell? So this is for him, for that couple, this is the premature ejaculation. Premature ejaculation, usually what we will give is the SSRIs. So one is the fluoxetine, small dose, you can start 10 mg, then go for 20 mg. Next is the paroxetine. So 12.5 or 25 mg you can. And next is the depaxetin, best depaxetin on demand. These two are fluoxetine and paroxetine daily dose you can give. On demand depaxetin you can give. So this is the premature. Another one is the delayed ejaculation. Sir, 30 minutes I am doing, sir, I am not getting, sir. Sir, 45 minutes I am doing, sir, I am not getting, sir. Delayed ejaculation. So again, this is the problem. If somebody sees this one delayed, so what is, sir, 45 minutes, what he is doing, sir? Really, most of the cases, no. In 100 cases, 3 to 4% is there. They will come, sir, really, I am doing my level best, masturbation, sexual intercourse, whatever I am doing, I am not getting. But I will get after 40 minutes. Book says more than 25 minutes he is not getting. After 25 minutes he is getting, that is the delayed ejaculation. For delayed also, very important is you should have talk, still whether that amount of stimulus his penis is getting or not. So you should, if you have patience and if you talk with them, they came to know. So in this way, you can categorize the sexual dysfunction, either the erectile dysfunction or ejaculatory dysfunction. In this way, if you deal, separate the components, and if you treat in this way, usually your andrology practice will rise. And also, if you are planning for a quiz program or something, usually what they will ask is, so on demand, what drug you will give for erectile dysfunction? Regular dose, what is the best one? And what are all the drugs causing erectile dysfunction? What is penile Doppler normal peak systolic velocities? So everything like this, it will come. So what is meant by definition of delayed ejaculation, definition of premature ejaculations? What is the minimum dose for the premature ejaculations? Like that, side effects of the drugs. And whatever, some patients comes to you, psychiatric patients taking clonazepam, another psychotropic drugs are there. They will have major component on the ejaculatory reflex. So you should have to take history in this way. So if you categorize and treat, usually most of these things will be, sorry. So they are treated. Next, consecutive minutes. This is a broad andrological prospect I had given actually. I'll conclude my talk here. Next, consecutive chances are there from Dr. Surendra side. Elaborately, we'll discuss erectile dysfunctions, ejaculatory dysfunctions, and fertility component in the form of severe oats, azoospermias. Everything we'll discuss and we'll proceed. Thank you everyone for your patience hearing.
Thank you, Dr. Surendra, for your beautiful insights on and an overview on andrology for urology aspirants and also urology residents. So I think because andrology is often a neglected topic for urology entrance examination, usually we tend to skip. You remember when we were preparing for our NIMS exam also, we tend to skip andrology part because hardly they are asking 1 or 2 or maximum 3 to 4 questions from andrology. Mostly they will be concentrating on topics like priapism, Peyronie's disease, or sometimes on this malleable or 3-piece implants. All these things are routine MCQs that have been asked in the past. But now, as you can see, the papers have evolved and now they are asking clinical scenarios like, as you elaborated about non-obstructive azoospermia, techniques of sperm extraction and all these things. So I think your video will definitely throw some basic insights on the overview of andrology. So thank you. What we'll do is we'll make future videos where we'll have a dedicated sessions on priapism, dedicated sessions on Peyronie's disease, sessions on penile Doppler. So we'll make short videos which will be useful for the urology community. Thank you very much for your time, Dr. Surendra.
Thank you, Harshvardhan. Thank you so much.